The topic today we are discussing is Leishmaniasis, its clinical features, diagnosis, and management. As already we discussed about what is Leishmaniasis. Leishmaniasis is a group of vector-borne parasitic disease caused by at least 20 different species of the genus Leishmania and are transmitted between mammalian host by infected female sandflies. This Leishmaniasis, when it is calling as a general term, it is called Leishmaniasis. In singular, it is Leishmaniasis. Primarily, this Leishmaniasis is a zoonosis, but Leishmania donovani and tropica are more preferred towards human being. So hence it is called anthropophilic. And this also we have already discussed. Distinct species of Leishmania cause different clinical manifestations that ranging in severity from self-curing lesions to life-threatening visceral disease. In India, we are more concerning about the life-threatening form of Leishmaniasis that we are calling it as Kala Azar, or another, it is also called visceral Leishmaniasis. Next, please. This is the general classification of Leishmaniasis. Leishmaniasis as a whole can be classified broadly into Old World Leishmaniasis and New World Leishmaniasis. This Old World Leishmaniasis mainly one can see in non-American region, and New World Leishmaniasis we can see only in American regions. In Old World Leishmaniasis, the main disease is visceral Leishmaniasis that occurs in India, Southern Europe, China, Northern Africa, Kenya. And this disease, visceral Leishmaniasis, caused by Leishmania donovani, Leishmania infantum, Leishmania tropica. And its later form, if drug taken improperly, it may lead to post-Kala-Azar-dermal Leishmaniasis, shortly called PKDL. And this condition is only seen in India and Sudan. In India, it is only 10% of total visceral Leishmaniasis cases, and in Sudan, it is around 90%. Out of total PKDL cases, 90% one can see in Sudan, and in India, only 10% is PKDL. And this PKDL is caused by Leishmania donovani and Leishmania infantum and Leishmania tropica. Similarly, cutaneous Leishmaniasis. In Old World cutaneous Leishmaniasis, that is commonly seen in Middle East, North Africa, and Asia, caused by Leishmania donovani, Leishmania infantum, Leishmania tropica, and Leishmania major. And the advanced form of cutaneous Leishmaniasis is diffuse cutaneous Leishmaniasis that is seen in Ethiopia and Kenya, caused by Leishmania ethiopica. And another form of disease called Leishmania residuans. This occurs after the recovery of cutaneous Leishmaniasis. In some person, it may occur. This is generally seen in Middle East, India, Southern Europe, and this is caused by Leishmania tropica. If now we can see about the New World Leishmaniasis, are also called American Leishmaniasis. This type of American visceral Leishmaniasis seen only in Central and South America, caused by Leishmania chagassi and Leishmania infantum, and post-Kala-Azar-dermal Leishmaniasis caused by Leishmania chagassi in Central and South America. Here, in New World Leishmaniasis, the cutaneous Leishmania is a major problem in Central and South America, caused by Leishmania mexicana, Leishmania brasiliensis, Leishmania amazonensis. And its advanced form, as like previous case, mucocutaneous Leishmaniasis caused by Leishmania brasiliensis, Leishmania guvenensis, Leishmania banamensis. This is major problem in Central and South America. And similarly, the diffuse cutaneous leishmaniasis is seen in Ethiopia and Kenya, caused by Leishmania ethiopica. And the last one is Leishmaniasis recidivans, caused by Leishmania brasiliensis and occurs mainly in Central and South America. Next, we can see about clinical features. Yeah. First, we can see about visceral leishmaniasis. And this also we have already discussed in brief. Visceral leishmaniasis affects the internal organs of human body, including spleen, liver, lymph nodes. Signs and symptoms include fever, weight loss, lymphadenopathy, hepatomegaly, and massive splenomegaly. So the patient looks like a protruded abdomen due to the liver and spleen enlargement. Even though splenic and liver enlargement is common in many other diseases also, but this is a peculiar characteristic of visceral leishmaniasis. At the same time, the other parts of the body, like extremities, hands and legs, are very thin and very, it is called wasted. It looks like wasting, means very thin from normal size. Laboratory tests may show pancytopenia and hyperglobulinemia, means increased level of blood cells as well as increased immunoglobulin level in the body. And complications include gastrointestinal bleeding, peripheral edema, acute renal failure, and secondary bacterial infections. And generalized hyperpigmentation is a late feature of visceral leishmaniasis. The other name for it is, as we have already discussed, it is called azar, comes from Hindi for black fever. Visceral leishmaniasis may take different forms, ranging from asymptomatic self-resolving disease to being fulfillment and life-threatening form. Fulminant and life-threatening form means full-scale life-threatening form it may become at later stages. This is post-dermal leishmaniasis. If the treatment is not proper for visceral leishmaniasis, after several years of treatment, the patient may experience this post-Kala-Azar dermal leishmaniasis. The name itself shows post-Kala-Azar, means after the recovery from Kala-Azar, this type of symptoms may appear in some persons after recovery, even after several years of recovery, if the cure is not complete means. So post-Kala-Azar is a cutaneous form of leishmaniasis, resulting as a complication of visceral leishmaniasis. It occurs months to years after treatment of visceral leishmaniasis. The majority of cases occur in Sudan, up to 50%, and in India up to 10%. And lesions are either indurated papules and nodules or areas of macropapullar hypopigmentations. Most commonly, this affects in face, trunk region, extremities. Oral mucosa and genital area also may be affected sometimes. Prognosis and treatment varies with location. In over 80% of Sudanese patients, the post-Kala-Azar dermal leishmaniasis lesion will resolve spontaneously within a year. Whereas in India, the rate of spontaneous resolution is much lower, but here it requires systemic therapies. Cutaneous leishmaniasis, this is most common form of leishmaniasis. Here, solitary lesions appear mostly on face, extremities, trunk region, and it's a typical multiple lesions do occur sometimes. The initial lesion is a small red papule which gradually enlarges up to 2 centimeters in diameter. Central ulceration is typical. Ulcers can be moist and exude pus or dry with a crusted scab. Sores usually appear on exposed areas of the skin, especially the face and extremities. The incubation time between an infected sandfly bite and a lesion development ranges from 2 weeks to 6 months. Lesions are usually painless. Most resolve spontaneously after leaving residual atrophic scarring. Time to resolution varies between 2 months to more than a year. Sporotrochoid spread with lymphocutaneous nodules may occur. Chronic disease can occur, and there is a risk of dissemination in immunocompromised immunodeficient patients. This is mucocutaneous leishmaniasis. Typically occurs after spontaneous resolution or typical treatment of the primary cutaneous lesion, and this may develop within months or after many years of cutaneous leishmaniasis. The lifetime risk of developing mucocutaneous leishmaniasis after cutaneous lesions caused by Leishmania brasiliensis is around 5%. So only 5% of cases may develop this mucocutaneous leishmaniasis after recovery from cutaneous lesions. Lesions usually affect the mucous membrane of the nose and mouth, but the mucosal surface of the eyes and genital tract can also be involved. Without treatment, ulceration of the mucosal surfaces and destruction of the underlying tissues can occur. Mucosal lesions are often painful and become secondarily infected with bacteria and sometimes leading to sepsis. And this can also result in extreme disfigurement. This is diffuse cutaneous leishmaniasis. This is results from an allergic response to the infection due to reduced cell-mediated immunity. Following the primary cutaneous leishmaniasis lesion, non-ulcerative nodules and plaques develop all over the body. Lesions may be numerous and may extend over the whole body and follows a chronic relapsing or progressive course. This is often difficult to treat, as like PKDL. This also we have discussed in brief, and Leishmania residuans. This is a kind of recurrence. Like PKDL, this is a form of cutaneous leishmaniasis recurrence in some patient with the good cell-mediated immunity. This occurs in patients with a good cellular immune response, and spontaneous resolution of the primary cutaneous lesion is followed by the development of new lesions around the edge of the primary scar. The lesions typically ulcerate, then heal. The cycle continues with a chronic recurrent course, usually over decades, if not treated. If treatment is completed properly, it will disappear once for all. Now we can discuss about diagnosis. The gold standard for the diagnosis of leishmaniasis is microscopic examination and a confirmation by microscope. So, like microscopic examination of a stained bone marrow specimen from a patient with leishmaniasis, showing a macrophage. Here in the picture, one can see the picture of a macrophage, which is a white blood cell, a type of white blood cell containing multiple Leishmania A mastigotes. We have already seen two forms of parasite. One is tailed promastigote and another one is a form called A mastigote. This is without tail. So here one can see the presence of A mastigotes with a nucleus. Red arrow shows the nucleus of A mastigote and a rod-shaped kinetoblast. This is also a small form of nucleic acid material. And visualization of kinetoblast is important for the diagnostic purpose. And this is the gold standard for the diagnosis of leishmaniasis. But here, the taking bone marrow is a very painful process, and at the same time, taking splenic aspirate also very painful one, but also riskiest one. 1 in 1,000 cases of splenic aspiration may leads to a fatal condition. Next, please. Yeah, serological tests available. The first one is direct agglutination test. In this, the blood sample is impregnated in filter paper, and that filter paper is mixed with saline in an ELISA plate. Then it will be serially diluted in that diluent. It will be serially diluted. Then that antigen will be added, and it will be incubated for a particular period. Here it is, for example, 18 hours it will be incubated, and the positive result shows high titers, means all the inoculated area will show positivity, and borderline results shows partial positivity, and the negative results shows there is no agglutination at all. Here in the picture it has been shown clearly. And another alternative test is available called RK39 immunochromographic test, or shortly called RK39 test. In this, patient blood is taken, a drop of blood is taken from a patient, and it will be diluted with the diluent buffer, and it will be allowed to move on a paper strip. Then the appearance of band will be noted. In negative, one can see only one band, and in positive, one can see two bands. But these tests are limited with its sensitiveness and sensitivity and specificity. So now we can see about the management of leishmaniasis. In the management, first we can discuss about the treatment strategies for leishmaniasis. In the chart, we can see in the slide, one can see the chart. What type of treatment strategies applied in East Africa and Indian subcontinent, one can see. Here in East Africa, combination treatment is available with pentavalent antimonials. 20 milligram of pentavalent antimonial SB 5 plus is a sodium stibogluconate. So 20 milligram per kg body weight per day, intramuscularly given, or it also can be given intravenously plus intravenously also it can be given as a infusion for 17 days. So treatment has to be given for 17 days daily treatment, and efficacy rate is 91%, and adverse effect is cardiotoxicity, pancreatitis, and hypertoxicity, odotoxicity, and nephrotoxicity. Issues to be considered for this type of treatment is painful to administer, and the monitoring of renal function is important, and audiometry also to be monitored wherever possible, because it may also lead to it is an odotoxicity material. Then pentavalent antimonials given as 20 milligram for 30 days, and this also having the same problem of previous, and efficacy rate is 94%. And amphotericin B, liposomal amphotericin B, LAMP it is shortly called, and liposomal amphotericin B 3 to 5 milligram per kg body weight will be given as an infusion, not as a direct drug. It will be given as an infusion with saline solution over 6 to 10 days, up to a dose of 30 milligram per kg body weight. And the main adverse effect of this drug is shivering, back pain, and nephrotoxicity. This is more than 90% effective, and end of treatment results in complicated and several end of treatment results only results for complicated and severe visual leishmaniasis in non-HIV patients. Observational studies required. Observational studies are required and require storage less than 25 degrees centigrade for the drug. These are all the issues related with the LAMP. In India, pentavalent antimonials are not at all useful, and we have also tried with other drugs like pentamidine. After pentavalent antimonials, pentamidine tried, miltefosine also tried, but all those things are not so efficient in Indian subcontinent. At present, the liposomal amphotericin B is a good choice of drug. About 10 grams per kg body weight is given as a single dose, or 3 to 5 mg per kg body weight daily given up to 3 to 4 days. And this is more than 96% efficient, effective. And the side effect is like the previous that we have seen for LAMP, shivering, back pain, and nephrotoxicity. The same problem issues like before, we have seen the same issues here. And combination treatment is more efficient than liposomal amphotericin B. For combination treatment, what they are giving, LAMP. Along with the LAMP, miltefosine is preferred daily for 7 days. This combination therapy is 98% effective, but the side effects, main adverse effects are shivering, back pain, nephrotoxicity. Since miltefosine is taken, this will give gastric irritation and hepatotoxicity also, along with the previous adverse effects. Another form of combination therapy is LAMP plus parmomycin. This is another drug of choice for treatment, but parmomycin alone is not efficient. But when it is combined with the LAMP, this is more than 99. This is 98% effective. But the same side effects are persisting. Combination treatment with the miltefosine plus parmomycin for up to 10 days. It will be a 99% effective one. And amphotericin B deoxycholate treatment is 93% effective. And miltefosine is an oral drug, which was initially developed for the treatment of cancer, but it was not listening cancer. But now miltefosine is given as a drug of choice for visual leishmaniasis in India. Particularly for the children aged 2 to 11 years, because this is an oral drug, there is no invasive procedure involved. The side effects are also very mild, gastric irritation and hepatotoxicity only. Yeah, treatment of visual leishmaniasis, PKDL, post-callosal dermal leishmaniasis. In East Africa, people are following a combined treatment with pentantimonials plus parmomycin. But also they are trying with pentavalent antimonials, and liposomal amphotericin B also they are trying. Miltefosine also effective in East Africa. In Bangladesh, India, Nepal, people are trying with the miltefosine 100 mg orally per day for 12 weeks for patients weighing more than 25 kilograms, and 50 mg orally per day for 12 weeks for patients weighing less than 25 grams. Then another drug regimen is amphotericin B deoxycholate, given 1 mg per kg per day by infusion, up to 60 to 8 doses to be delivered in 4 months. The previous miltefosine is graded as A plus, and the second amphotericin B deoxycholate is graded as a C, and liposomal amphotericin B is graded as C plus, given 5 mg per kg per day by infusion 2 times per week for 3 weeks for a total dose of 30 mg per kg. This is treatment regimen for cutaneous leishmaniasis. So for treatment for old world leishmaniasis, cutaneous leishmaniasis, and new world leishmaniasis are different. For old world leishmaniasis, 15% parmomycin plus methyl benzomethnium ointment for 20 days given as a local treatment. As an ointment, it is given to apply on the affected area. Intralesional antimonials plus cryotherapy also given in some cases. Systemic treatment includes oral fluconazole 200 mg for 6 weeks and pentavalent antimonials for 10 to 20 days. Pentavalent antimonials 20 milligram per kg per body weight per day plus pentotoxifylline 400 mg 3 times a daily for 1 to 20 days. These are all for old world leishmaniasis, Leishmania major. And old world Leishmania tropica, Leishmania infantum, we have to go for thermotherapy. Thermotherapy is nothing but exposing the affected area for elevated temperature for a particular defined time. See here, it is for around 50 degrees centigrade for 30 seconds. And this has to be given along with the pentavalent antimonials with pentavalent antimonials alone or pentavalent antimonials plus oral allopurinol that will be effective, if more effective. In New World Leishmania, cutaneous leishmaniasis, particularly New World Leishmania mexicana, 15% parmomycin plus 12% methyl benzothione ointment is given for topical treatment, local treatment. Then comes New World Leishmania brasiliensis. Local treatment include thermotherapy, 1 to 2 sessions with localized heat, 50 degrees centigrade for 30 seconds. Systemic treatment includes pentavalent antimonials and liposomal amphotericin B. New World Leishmania panamiensis and Leishmania guineensis includes local treatment, intralesional antimonials 1 to 5 ml per session every day, 3 to 7 days for, and systemic treatment includes pentamidine, isothianate intramuscularly on alternate days. Pentavalent antimonials should be given 10 to 20 days. Oral miltefosine is also effective and graded as B. Mucocutaneous leishmaniasis. This is common for any new world leishmania, new world leishmania species, and systemic treatment regimen includes pentamidine isothianate intramuscularly on alternate days for 3 days, and pentavalent antimonials 20 mg per kg per day plus pentophyllin 400 mg 3 times daily for 1 to 20 days, and liposomal amphotericin B also given. And the other management strategy includes avoiding sandfly bites. This is considered as a major one because one can avoid the Leishmania bites by covering full cloths. If the whole body, if it is covered by cloths, then it will be difficult for the sandflies to bite. And avoiding visiting the regions affected by Kala-Azar or affected by Leishmaniasis. If there is no way one has to visit those areas, then they have to, those people has to make utmost protection to avoid sandfly bites. As we already discussed, sandfly generally lives in mud houses, mud walled houses, in the cracks, particularly in the cracks of the mud-walled houses. Generally, it lives nearby the cattle sheds. Those areas to be avoided when visiting the Leishmania endemic area. Second thing is living in concrete houses. This is a choice. This is a choice of choice for avoiding this leishmaniasis. And recently, WHO has funded for giving for constructing concrete houses in many affected villages of Bihar and UP to avoid the breeding of sandflies. Third choice to avoid this leishmaniasis is sleeping in the bed nets. Sleeping in the bed nets, particularly bed nets if it is treated with insecticides. So that will be more preferred one to prevent sandflies biting. And also seeking medical assistance if symptoms appear. One should not make delay. One should get immediate medical treatment or medical assistance once the symptoms appear, particularly the febrile illness, fever-like illness. If it appears, one should take immediate. One should get medical assistance immediately. In the endemic areas like Bihar and eastern parts of Uttar Pradesh and parts of West Bengal and the northern parts of Jharkhand, this is the hotspot of leishmaniasis, where lot of illegal medical practitioners are there. Quacks, they are generally called. So what they used to give some paracetamol tablet for the fever cases without knowing the real cause of the fever. Also, it is the practice of the people of those area. If it is correctly saying, not only those area, the people of whole India is doing directly. They are going to pharmacy. They are getting self-medication. So those things to be avoided, and they have to get proper medical attention immediately to prevent the spread of leishmaniasis and to prevent themselves affected by leishmaniasis. Thank you.